Thank you very much, Andrew, and thanks to the audience for joining us today. My job is really to introduce the concept of outcomes and to look at what we need to be doing in clinical microbiology to commit ourselves to patient outcomes in terms of a continuum of care. I think we're going in that direction already, but we also need to look more carefully at what we do in microbiology and how it affects actual patient outcomes. In a quote here in the first slide, this is from Milton Friedman, one of the great mistakes is to judge policies and programs by their intentions rather than by their results. And oftentimes that's what happens. We put into practice a protocol without really knowing what happens in terms of how it's accepted, how it's used by the clinicians, or what happens to the patient themselves after the introduction of the protocol or procedure. So what are the reasons for some of these things that are going on in medicine? Medicine is changing drastically and rapidly. First of all, we have an increasing healthcare costs problem, and that is basically because of several different issues. One, all of us are getting older. I am for sure. We're all baby boomers, or a lot of us are. We're also getting to become more immunocompromised as we find that healthcare is able to keep us going for longer periods of time. We have a much greater number of insured patients now who can actually get some health care, and they go to health care. And finally, and we all know that in microbiology, we also see increasing antimicrobial resistance with more pressure both on the laboratories and on the clinicians. So what does this necessitate? When we look at what happens or what the impact is, we have to have healthcare reform. Healthcare, the way we've seen in the past, just cannot hold on anymore. We also need antimicrobial stewardship, and a time when I don't think it's taught as much anymore in medical school. And we need to have a better understanding of outcomes of our economics. We have to see what is it that we do and how does it apply to our patients. So if you look at, I got this from National Geographic in January 2010. If you look on the right-hand side, this is the cost to the countries, or what the countries spend per person in their country. And on the right-hand side is the average mortality rate, the average number of years that patients or people live in those countries. And you can see many of the European countries, including New Zealand, Japan, Spain, Finland, Australia, all have pretty good low cost per patient and fairly extensive age before which patients pass on. On the red line, here's the United States. We pay the most for any patient, and yet our mortality rate remains only on the average in between and actually less than many of the European countries. So this is not just health care in terms of medicine, but also in terms of all aspects of health care as well. So what is going on then? We've got a changing landscape of health care. We have the 2010 Patient Protection and Affordable Care Act, or the ACA, and that's the Obamacare. And that really, the goals of this whole aspect is to increase access to health care, which I mentioned at first, that we are getting more and more patients with actual access to health care. We're improving the quality of care. We're increasing the accountability and efficiency. And this really includes clinical value, patient satisfaction, and decreasing costs. All of those CMS and the others are pushing not only hospitals but healthcare to proceed with. We are now going to a value-based purchasing model, reimbursement based on quality metrics rather than just on studies being done or testing being done. And also, many of you may not have heard of accountable care organizations, which the government is sponsoring, which basically says that they give one pot of money at the very beginning of any insured patient, and that pot of money will take that patient through being well, going in the hospital, getting out of the hospital. In other words, the responsibility is up to the organization that's taking this ACO on to take care of that patient, which means that we really need to be looking at how we act and how we best can afford these items. So what does one get for the resources spent, I guess, is the major question one can ask. So again, the changing landscape, we also have a huge maturation of new technologies. We've got the automation, we've got nucleic acid amplification tests, NAT, we have mass spectrometry, and down the road we've got all kinds of other tests coming up all the time. So we have an increasing number of test menus, decreasing understanding of test application and interpretation by clinicians in general. We were discussing this with Dr. Lopansri earlier. Clinicians coming out in med school don't have the support anymore as they did in the past, And they're bombarded by so much information that they can't gather all the information that we have in the laboratories. We also have to look at clinical consensus practices. What are we doing, and how do we actually apply those? No longer is the individual clinician really supposed to work like that. You really work to need as teams. And we need to have algorithms to remind people so we don't miss something as we move forward in trying to make a diagnosis. Secondly, or thirdly, I should say, changing laboratory infrastructure and dwindling personnel resources is a big, big issue, as we all know in the laboratory. There's becoming a severe shortage of well-trained technologists, and many times we have to train new technologists or technicians initially in the laboratory, which takes much longer period of time with lesser amount of actual background. And number of graduates fell from 6,000 to 2,000 only during the same period. 70% closure of schools. And look at what happens at the end. We're actually predicting that we're not going to have enough people coming out to support all the necessary positions that we will have in laboratories. So what does that mean? Well, we also have to look at post-analytical issues. In the past, if you look at CLSI and we look at CAP, post-analytical basically meant, are we getting the reports out appropriately? Are the reports reading correctly? Are we making comments? But we rarely looked beyond that. We rarely looked at actual patient outcome. What happens to those studies? What actually was performed by the clinician based on the results we give them? And what was the outcome in the patient?